Hi, this is Brian Kim. I'm going to share with you case number 109, the best way to do cataract surgery series. This is a patient who is a +6 diopter hyperope, and the lens implant we put in is a 28.5 diopter lens for plano. And so I'm going to talk briefly about the surgical challenges and considerations with the small eye. With the small eye, the first issue is you can have a shallow chamber, and also you can have a lens that's more convex. And so during capsulorhexis, it's really very important to make sure you continue to pull centrally when you're doing the rhexis. And then during phaco, because the cornea is closer to the action, you really want to do a technique that utilizes less ultrasonic energy and there's less manipulation, potential trauma to the corneal endothelium. So I use a cotton tip to steady the eye, and I use a corneal marker which will help me to center and size the rhexis. I then make my paracentesis incisions first on the right side and the left side. First, I make my paracentesis incisions first on the right side and then the left side. And I make the incision flat to the iris plane, which will allow me to create a nice corneal shelf, which will allow me to achieve a self-sealing incision. I inject some intracameral lidocaine and then some dispersive viscoelastic to coat the corneal endothelium. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, turn the eye towards me, and then I enter. By turning the eye towards me, I'm able to actually get really nice control of the actual length of my incision. So I go in with T sideways and I puncture. You can see there's a little bit of laxity there as I punctured, but it got through. And I grab the right side of the tear, which creates a flap. And remember, I'm being mindful, pulling centrally as I'm making the rhexis, because it wants to go outward. So pulling more centrally than I normally do, going around being mindful so that the tear doesn't radialize here. So that was thankfully fairly uneventful, decompressing. And this is a capsular phonic titer dissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, come out, decompress on the left side, the lens is already loose, and then hooking it on the right side, and it's spun quite easily there. Irrigating the surface of the eye, and then lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, turning the phaco tip vertically sub-incisionally, getting into the lens, and then cutting the lens, crushing the lens as I bring the instruments together, and it bisects the lens. Placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, which crushes and divides the right heminucleus. That is double chop and cross chop. Using some vacuum, I lift that first quadrant up, crush the lens between the instruments, and emulsify the lens pieces. Placing the chopper around the second quadrant, hooking it up, and it prolapses into the anterior chamber. Positioning the lens piece on the tip with the chopper, and then using some vacuum to emulsify the lens piece, and then crush the lens piece into smaller pieces, and then emulsify some more. Turning the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, which is deep in the bag, crushing and bisecting the lens, using some vacuum to grab that third quadrant, crushing it between the instruments and emulsifying the lens piece. Placing the chopper around the fourth quadrant, crushing the lens between the instruments, and then emulsifying the lens pieces. Using the chopper to grab that last piece and then emulsifying it, and then grabbing the epinucleus from the anterior aspect, and it tumbles out quite nicely with the vacuum, making sure the chopper is deep. If I take the chopper out, push BSS in, take the phaco tip out, I go in with the INA handpiece with the irrigation off and then activate irrigation. Start subincisionally removing the cortical material, which comes out quite easily in this case. I switch to polish mode and I start to polish underneath the rexus edge here, removing the lens epithelial cells along the rexus edge. And then I'm polishing on the posterior capsule surface as well. This polymer tip is really very, very safe. Because it's a disposable tip, you don't ever have to worry about any potential sharp edges that might cause a posterior capsule rupture. We want to push some BSS into the subincisional capsular fornix here, making sure there's no lens material there. It's nice and clean in this case. And then I'm going to inject some cohesive viscoelastic to fill the capsular bag. And then I'm going to start to sweep under the rexus edge, underneath the left side first of the lens epithelial cells. And then on the right side, doing the same thing. I've switched to really just polishing under the rexus edge and trying to avoid going too deep into the capsular fornix there. This is a big lens, so I have to widen the incision with the blade. Again, 28.5 diopter lens, you have to widen that incision, delivering the single piece acrylic lens into the capsular bag. It gets a pretty thick lens here, as you could tell. Go ahead and place the INA tip, irrigation off, activating irrigation, disengaging the haptics off the optic, placing both haptics in the bag, getting under the optic, tilting it, rotating at 90 degrees, removing all the viscoelastic from within the bag. Repositing the optic. Polishing under the rexus edge of any fine material that might be there. Turning the lens. Switching to visco mode. And then I'll hydrate my incision. So again, this is a very small eye, 6 diopter Hyperope. The lens power is 28.5. These cases, again, you can have quite a shallow chamber. You can also have a very convex anterior capsule surface. You have to be careful about the rexus, making sure you don't radialize as you do the rexus. Try to pull more towards the center with these cases, not dissimilar to doing a rexus on a young patient. You also want to make sure that you do minimal ultrasonic energy in the anterior chamber, since the cornea is closer to the anterior chamber in these cases. And that's why double chop, cross chop mechanical fracturing techniques are really ideal for this situation, but quite frankly, for any situation, because by utilizing less ultrasonic energy, that's always a good thing. And being able to use your instruments to crush the lens pieces just gives you exquisite control with lens disassembly. So I hope this was helpful to you, and I thank you for your attention.